Hello and welcome to the first ever episode of a brand new podcast brought to you by the North East London Cancer Alliance. I'm Steve Bland and this is called Taking Control of Cancer. It's like a how-to guide to help you overcome common myths, fears and barriers to cancer prevention, diagnosis, treatment and care. In this series, we want to provide both patients and healthcare professionals with tangible things that they can do to help when it comes to cancer. And while we know that not all cancers are preventable, there are things we can all do that can make a positive difference to the health and well-being of our family, our friends and our colleagues. Now, in this first episode, we've got a really exciting one. We've gone on the road. We've gone to St Bartholomew's Hospital in London, and I've been very lucky to speak to the Chief Executive of St Bartholomew's, Professor Charles Knight. I'm going to give Charles the big build-up. He is a consultant cardiologist, and as I said, the Chief Exec of St Bartholomew's Hospital. He was also the Honorary Secretary of the British Cardiovascular Society from 2008 to 2011. He is a specialist in alcohol septal ablation and a Fellow of the Royal College of Physicians. And in March 2020, he was seconded as the Chief Executive of the NHS Nightingale Hospital, which was, I'm sure you remember, it was established to care for patients during the COVID pandemic. In July, he was awarded the Freedom of the City of London in acknowledgement of his role in the NHS's response to the outbreak. And in October 2020, he was awarded an OBE for services to the NHS and people with heart disease. I should say as well that Charles is chair of the North East London Cancer Alliance board, so it makes him a really good person to get to grips with exactly what a Cancer Alliance is and what his role is. So that's where we started. Okay, so Charles, thank you so much for having me along to St Bart's. I guess we'll just start off before we go into your sort of background, where it all started, how it all started. Just tell me a little bit about your role with the Cancer Alliance as chair of the board.
So it's a great honour to be chair of the North East London Cancer Alliance. Cancer Alliances are really important vehicles for transforming care within a region, and our region is North East London. As chair of the Cancer Alliance, my job is to make sure that the Cancer Alliance gets the profile that it needs within the organisations in North East London, to make sure that everyone knows what it's doing and that the top of those organisations, the chief executives, the chief operating officers and so forth, buy in and give the Cancer Alliance its support.
So what does, in very layman's terms, as someone that perhaps doesn't know anything about Cancer Alliances, there are 21 I think in the country, what does a Cancer Alliance do and where does it sit in the sort of NHS ecosystem?
So what's really important within cancer care for patients with cancer is not just delivering treatment, but coordinating care, because a patient with cancer has to go through almost every part of the health ecosystem. And each hospital, each GP surgery can provide great care, but unless those interactions are coordinated and unless we bring those organisations together, we're not going to get the optimum pathways of care for cancer patients. And that's really important. So Cancer Alliances were formed to work to bring together clinical and managerial posts within each healthcare organisation, to bring them together and make sure that the care for patients is as seamless as possible. And it is care, not just treatment. And one further thing the Cancer Alliances are really focused on is it's not just care, it's also prevention. So we're working with primary care and public health colleagues as well to try and promote the prevention of cancer. So it's not a doing role, it's a coordinating role.
And if we're talking specifically about the North East London Cancer Alliance, you know, while all alliances might have the same or similar objectives, a similar purpose, there are some very specific challenges for the alliance and for people working in North East London, aren't there?
Yeah. So first of all, North East London, I always think sounds like a sort of, borough council. It doesn't sound like anything very important, but we look after a population the size of Wales.
Wow.
So it's a huge population. It's the same size as looking after Glasgow, Edinburgh, Newcastle and Bristol.
Wow.
And that just gives you a sense of how enormous London is, because we're only a fifth of it. But it's a very big area, and it's a unique population. It's the most diverse and deprived population in the country. For example, at the trust where I work, Barts Health, we have approximately 120 different languages spoken. So it's a very different population from, say, that you would see in Cornwall and the southwest. A radically different population, many diverse ethnicities, high levels of deprivation, and that places additional duties on us to make sure that we reduce healthcare inequalities and we bring up the standard of care to what we would all want. And that means reaching out to difficult-to-reach groups that maybe culturally and economically find it very difficult to access care.
It's clearly a huge challenge, but there is loads and loads of work going on. I think in the later episodes of this podcast, we're going to talk about some of the programs that have been put together by the Alliance. Let's just go back a little bit before we get into all that. I want to learn a little bit about you and how you came to be chair of the board. How did you get into healthcare, and I guess what were your motivations? What were your passions as a young Charles?
So my background is clinical, so I'm a doctor, and I went into cardiology. I was an interventional cardiologist, now I'm a general cardiologist. I went into cardiology, I think most people, it's more an emotional than a hard-headed decision. I think I chose cardiology because I admired the people that were teaching me that were cardiologists, and I wanted to be like them. It was a very lucky time for me, so I started my medical training in 1982, which seems like a complete dinosaur. But during that period, when I was an interventional cardiologist, we really had a huge expansion in what we could do for patients, putting in stents into heart arteries, and particularly with relevance to this role. It's one thing to have the technology, it's quite another thing to coordinate care in a way that is meaningful for patients. So if you have a heart attack, you have to have a stent fitted within about 150 minutes of your call for help. And putting the stent in is not always, but is often relatively straightforward. What isn't straightforward is getting ambulance crews trained to read ECGs and to coordinate the care and bring them to heart attack centres. I think that's got a lot of crossover with what I was describing as the role of the Cancer Alliance. So we know what works for cancer. We have amazing improvements in treatment. Almost every month something's coming out that a new immunotherapy is improving people's chances of survival. But none of that matters if the patient can't get it and can't get it in a timely fashion. So I think that's the crossover. To continue about why I was the chair of the Cancer Alliance, I'm the chief executive of St Bartholomew's Hospital, which has a major cancer centre within it. It's the second biggest in London. So I was asked, as that would sort of fit the portfolio best, to be the chair of the Cancer Alliance. Each of the sort of big work streams within North East London have one of the hospital chief executives as their chair or SRO, Senior Responsible Officer. So I was very fortunate to be picked for the cancer one rather than one of the others.
Do you ever get to go back into the clinical world, or are you just office based now? So
I stopped doing the stent procedures about 5 or 6 years ago now, but I still see patients in outpatients, and I think that's really really valuable to not lose that contact.
So interesting what you say about bringing the services together and talking about the role of the alliance. That seems to me an area, in my experience, that maybe the NHS hasn't always been great at. Coming together, even hospitals that are 5 or 10 miles away don't always seem to work together in the way that a patient would want, and that's I guess the essence of an alliance, isn't it? To bring everything together.
Yes, for a long time the NHS was, to my mind, unfortunately set up that each hospital or each group of hospitals was a business that was in competition often with other NHS hospital groups nearby. And I don't think that was ever a really helpful concept, and it was driven by a desire for those hospitals to be as efficient and as possible, and to get better funding by being more competitive. But it had a big negative effect in that organisational boundaries became very rigid, walls went up between hospitals, and it became much more difficult to organise patient care around the patient's needs rather than the hospital's needs. I think that has changed a lot over the last few years in a positive direction, and the Cancer Alliances are in many ways a manifestation of that. And I think everyone recognises, as I said a few minutes ago, that every single bit of the system has to work and coordinate with each other to treat something as complicated and as long-term, hopefully, as cancer treatment.
How do you think your role has changed? You've been the chief exec now for a few years, I think, haven't you?
Yes, about 9 years.
Yeah, so how has your role changed, and how maybe has the role of this hospital changed in those 9 years?
So I think the core mission remains the same. The hospital here at St Bartholomew's, which has, must get the plug in, has just celebrated its 900th birthday.
900, wow.
The oldest hospital in the UK. So we've been providing healthcare free at the point of delivery for 900 years. Wow. The hospital, really since the turn of the century around, has concentrated on cardiac and cancer care. So we're a specialist hospital. We don't have an A&E department. We have a heart attack centre. We have a acute cancer assessment unit. But those are our big specialties. We have some other smaller and very high profile, very good specialties: fertility, endocrinology, specialist respiratory. So our mission has not been the same, has been the same over the 9 years since I've been here. But I guess the atmosphere has changed, as I was saying, much more towards cooperation, and much more towards working across organisational boundaries. And I think that the story of the COVID pandemic did accelerate that. We all had to work together, both in cancer, in cardiac, and in particular in intensive care. We had to work together much more closely, and I think those links have maintained.
How do you think, I was going to ask you about the pandemic, because obviously you played a leading role with the Nightingale Centre. How do you think it has changed, particularly with a focus on cancer? How do you think it has changed, from your perspective as a clinician, the way we treat patients, the way, I know it's changed a lot of, a lot of face-to-face has become over the phone, for example, or Teams calls, Zoom calls. What are the biggest ways that it's changed the way that people do their jobs?
So it was a massive challenge for the NHS, as we all know, and I think the NHS rose to that challenge really magnificently. The simple fact is within the NHS we've always run on a very tight bed base. We run at very high occupancy levels compared with our peers in Europe, and that did leave us much more exposed when the pandemic hits and we needed to create many more beds. So back in March 2020, we had approximately 800 ITU beds in London. And the modelling that we were shown suggested that in about 3 weeks' time we would need 8,000.
Wow.
And that's what led to the creation of the Nightingale Hospital, because the XL Centre in East London was the only place big enough where you could dream of accommodating that number of patients. And of course we didn't have the staff. We only had 800 beds worth of staff. But it was a huge collaborative effort, and I think some of the things we learned about real-time governance at the Nightingale, about better induction for medical staff, have been positive and have persisted. As you say, we moved by default at enormous speed from almost entirely face-to-face patient interaction to a lot of virtual interaction, initially by phone because we didn't have the technology, and then increasingly via video conferencing. And I think obviously we went probably too far with that, and patients do need to be seen face to face, and they do need the reassurance of actually a physical contact with the hospital. I think that we're now, 4 years later, we're beginning to calibrate that better, and it's clearly what patients want is to be seen face to face when they need it, but also to have the convenience of a quick call with a doctor for a follow-up appointment, rather than wasting a whole day travelling in and travelling out.
Yeah, that's huge for patients, isn't it?
Yep.
Because I can remember when my first wife died from breast cancer nearly 6 years ago now, and I can recall sitting in a hospital waiting room all day, knowing that we were going to get some bad news at some point that day, and it really could have been a half an hour phone call or a Zoom call.
Yeah.
But you just didn't. It just wasn't a thing back then.
No.
5 or 6 years ago.
And we talk about waiting times for cancer diagnosis and for cancer treatment, and in North East London we've made an enormous strides to reduce waiting times, but the NHS is very good at sort of using numbers and percentages and acronyms, but when we think about those reduction in waiting times, that is a huge reduction in anxiety. It's a huge reduction in all those ghastly waits, waiting for a scan result. Is it going to be clear? Is it not? The human cost of delay is extraordinary. And I think we sometimes don't focus on that enough. We talk about, the spreadsheet showing a 5% improvement without us constantly being reminded what an enormous benefit that is to people.
You've nicely led me into some of the amazing work going on in North East London. Big improvements on the waiting time picture. Despite maybe the picture nationally maybe not being where we want it to be in terms of people getting seen and getting treated as quickly as we want, but in North East London particularly, we've seen big improvements, haven't we?
Yes, and that's a testament to the whole system and all the provider organisations within North East London. Real focus on this. So we've reduced the backlog of patients waiting too long by 40%, and we've achieved the 75% faster diagnostic standard. So that's the sort of non-emotional way of saying what I was just saying. It's still far too long nationally, and even here. Everyone should expect, if they have possible cancer, to get the results as soon as possible. But we're making good progress, and I'm very confident we'll continue to improve on that.
Let's talk about some of the other work going on in North East London, and particularly around some of the diversity challenges that you alluded to earlier. Let's just outline them a bit clearer. Huge diversity in terms of ethnicity, languages, socioeconomic factors. Somebody was telling me in one borough alone, 100 different languages. I'm from up near Manchester, And I know we have, similar challenges there, but I think it even down to the logistics of I read the Alliance website some weeks ago, and I think there's no word in Romanian for screening.
Yeah.
There are huge challenges, but there's also very small niche things that are quite difficult to address in this area too.
Yes, I think, first of all, the immense challenge of economic deprivation. Young women with breast cancer telling some of our oncologists that they know they've got the disease, but they feel fine and they're not going to have any treatment because they can't afford it. Who's going to look after the kids? How can they afford to get on the bus to come here? I mean, that's happening, and it's shocking that that's happening in the UK in 2024, but it is. So how the economic problems that people have just in terms of getting to hospitals, being able to take time off work, arranging childcare. So that's a huge issue. You've highlighted the issue about some communities that don't speak English, how difficult it is, cultural issues around breast cancer in particular, around people not wanting to present. But yes, we've done a lot of outreach projects. So we've been increasing awareness of uterine womb cancer among Black African, Black Caribbean and South Asian women, and that's in collaboration with the Eve Appeal, and that actually got an award for diversity and inclusion communication. So that's a lovely little example of a difference you can make. And then other hard to reach groups. We're working with Jewish communities, Polish, Lithuanian, Turkish Cypriot, all to increase, as you were saying, decrease the barriers to screening. And that highlights the role of the Cancer Alliance in not just in treatment, not just in care, but in prevention, because clearly that's the best of all.
That's what I was actually going to ask you. Do these challenges, and we sort of alluded to it earlier, these challenges really highlight the importance of alliances, don't they? Because it needs a coordinated approach, not just with healthcare professionals, but you've got an amazing Maggie Centre here, for example, which we're hoping to go to during the series. But that kind of place is fundamental to addressing health inequalities.
Yes, and the faster, the easier, the more easy it is to access care, the impact of inequalities is lessened because it's easier and quicker for people to do it. And so often as well, it is only people that know a bit about healthcare and that have that sort of background that can really navigate the system and all the complexities, and that's not good enough. It has to be easy to navigate, and the NHS is not easy to navigate. Too many times you don't have the right number to call if you want to change your appointment and all of these things, and all of that impacts much more upon more deprived communities because they don't have the time and they don't have the resources towards optimizing their care pathway. How do you
feel about the future for cancer care in North East London? Clearly a huge amount of work going on, a huge amount of work that's gone on already, and a huge amount of work still to do. But how do you sort of assess the future of cancer care in this part of London?
So I'm optimistic. I think the first thing to say is that the whole pace of cancer treatment and cancer research is just amazing at the minute. So there are people alive now that wouldn't have been alive 5 or 10 years ago because of new advances in care. So that is the background. There's new hope in all sorts of cancers that wasn't there before. And I can't help but think that will continue, probably escalate. Then there's new technology. We've been doing a project with artificial intelligence to read chest X-rays, and that sort of technology has huge possibilities in terms of, again, shortening waiting times for scan results. If it's normal, the computer can say it's normal itself. You probably get the result in a second. Not now, but in a few years. So you can see how that will impact. Blood tests for detecting cancer recurrence or even cancer occurrence, those are all on the horizon very, very much. So there's a huge technological advance in terms of treatment, screening, AI, that have to make you very positive. The Cancer Alliance, as I said, is not going to do any of that, but what it is going to do, I hope, is to make sure that all those advances are absolutely accessible equally to everyone within North East London. So I think the more that can be done, the more tragic it is if someone misses it, if someone ends up with stage 4, not stage 1 cancer, because so often they can be completely cured and have a normal life expectancy. So I think our role, our duty, and the burden on us almost becomes more as we see all those potential for better outcomes, and we've got to get them to the right people.
Yeah, so much of that is incredible, but if we're not getting people in the door into primary care in the first place, into their GP surgeries in the first place, then it can do whatever it wants, can't it? And that's the challenge, I guess.
And there's still, not maybe so much within North East London, but across the country, there's still such a variation in care and in access between one place and the other, and that's not right, really.
And I think going back to COVID clearly had a huge knock-on impact on particularly on something like lung cancer, where we told people to stay away from surgeries with coughs, and persistent cough is one of the main symptoms of lung cancer. So we're still dealing with that that sort of backlog and that after effect, aren't we? Yes,
I always hated the slogan, the NHS should be there to protect us, not vice versa.
You mentioned a national picture. I don't want to get political at all, but people will probably listen to this after the election in July. Whatever government we've got, there's a huge job, isn't there, to come up with a really good plan to take cancer treatment forward.
Absolutely, and good cancer care is expensive, and now it's getting more expensive because it works. So some people are on chemotherapy, immunotherapy drugs for years. You used to have 1 6-week course of chemotherapy, and that was that. And every success is adding to the need for ongoing treatment. And some of these drugs are very expensive, and some of the scanners are very expensive. So as a nation, we need the resources to enable people to benefit from these advances in medical technology. And I don't think it's a political point to say that we need our GDP to be growing, because in the future, countries that are wealthy and are growing are going to be able to give their citizens dramatically better care than countries that aren't. So I think in order to improve cancer care, it's not just a question of money at all. It is a question of coordination. All the stuff we've been talking about is not just better for patients, it's also more efficient and saves money. If you can have people seen faster, more early stage cancers caught, ultimately saves money. It makes people more economically productive. So it's good for the public purse as well as the patient, but there are escalating costs in an aging Western population. and a country like ours, you can't see that costs are ever going to reduce, and it's up to the government to put that case to the public and say, this is our strategy for dealing with this issue.
Yeah, that's the that's the word Cancer Research UK have used. They want a national cancer strategy, which I think we've had in the past. But they'd like to see again. I saw a piece. We're recording this on the 19th of June, and I saw a piece they put on their social media just today. Calling again for that, and they called for it. A couple of weeks ago, along with the family of my good friend Dame Deborah James, asking for that national cancer strategy. Whoever wins, whoever has won the election, it needs a really good plan, doesn't it?
Yeah, and I think patients deserve that. And the UK has so many fantastic advantages as well. We have, amazing researchers here. We're really leading the world in so much of this. We have great AI resources. We have a coordinated healthcare system where we can, if we look at it properly, we can really get good data out of the NHS. So we've got huge potential here to engage not just with patients, but also with pharma companies and drive research, which again is good for patients and the public purse. So we're in a strong position. The governments need to support us to maximise the benefits from that.
Let's bring it back now to East London. What are you personally looking forward to over the next year, the next 2 years, the next 5 years, in terms of what the Alliance could achieve?
So I think COVID has cast a long shadow, as we've discussed, and many of the delays and many of the problems in terms of coordination of care have resulted to some degree from all the things you were saying. Stay away if you've got a cough, and the vast impact of COVID on hospital waiting times and all the rest of it. So I think that shadow is beginning to lift. So I'm looking forward to real focus and real sustained improvement on those targets for speeding up care. I think there's some really exciting developments coming along. We've got the Breast Cancer Centre proposal here, which I'm really hopeful will come off. And if that happens, that will be amazing. That's a coordinated breast cancer centre for the inner part of North East London that will address a lot of the issues we've been talking about today. And as I said before, lots more of working with partners, working with primary care, working with public health, stimulating research. I think the future, I hope, is really bright.
And do you think, with all that work going on, the role of the Alliance in all that will become even more important?
I think so, yes. The more we can do for patients, as we've said, the more we can do, and we can do so much, the more care needs to be coordinated so that it reaches everyone all the time in all parts of our system.
It's a heck of a jigsaw to put together, isn't it? You guys kind of sitting at the, in the senior roles in the NHS. It's a huge challenge to coordinate, all these moving parts, all these challenges that come along every so often that you don't expect, like COVID. It's a massive challenge, isn't it?
It is. I really, really hope I retire before the next pandemic.
You don't fancy another one?
But no, I think what is nice to see is how willing all parts of the system are to collaborate. We have a very good group of providers and organisations within North East London that really are bought into the spirit of collaboration, and that's why we've had success as an alliance, because there's a good spirit and people want to make this unique community healthier.
Is that something about the people of North East London?
I think so, yes. I mean, I've worked here for so long, I don't know what anyone else is like elsewhere.
But it's that collaborative approach, isn't it? Yeah, everyone wanting to muck in and help each other.
Yeah, and that's, I'd like to think that that's a feature of the country and of the NHS, but it's certainly evident here.
Well, thank you so much for your time, Charles. It's been really interesting to meet you and hear your thoughts on the future of cancer care in North East London and the future of the Alliance. Thank you so much for having us.
It's been an absolute pleasure. Thanks for having me.
Thank you so much for listening to the first episode of Taking Control of Cancer, the podcast brought to you by the North East London Cancer Alliance. Make sure you tune in for the next episode, and in the meantime, do go and follow the North East London Cancer Alliance on all social media.